Hello. Today, I'm proud to present using a rapid strategy and integrated product team for best practices. I am joined by a fantastic and talented panel that will highlight for you and show how we're using digital and data-driven strategies for fighting COVID-19 with a very novel platform that we developed in tandem with some fantastic partners. Here are our disclosures. And it is our aim that at the end of this session, those that are attending will be able to do four things: rapidly analyze data, plan, iterate, deploy, and scale information platform solutions using our novel rapid strategy. We also hope that you will leverage the lessons learned from the Department of Defense's Joint Artificial Intelligence Project Salus experience. We'll show how the Project Salus predictive risk models were developed and validated. And finally, we hope to convey how all of the audience members will be able to recognize how the Salus predictive models can help inform and prioritize resource allocation, as well as the prioritization of COVID-19 vaccination distribution. What is Project Salus? In overview, it is a platform that was developed by the Department of Defense's Joint Artificial Intelligence Center, named after the Roman god of health and protection. My colleagues will deliver great detail into how the platform was developed and what data was used.
In the early months of 2020, the world, indeed the United States, faced a once-in-a-generation crisis in dealing with COVID-19. The Department of Defense, and in particular, the Joint Artificial Intelligence Center, or the JAIC, sought to leverage our vast expertise to try to figure out how we can develop products and capabilities in response to the COVID crisis. In particular, we adopted a strategy commonly used across the Department of Defense in acquisition. Specifically, we developed something called an integrated project team, or an IPT. An IPT, simply put, is a team comprised of individuals with vast differences in expertise, knowledge, skills, and abilities, and other capabilities designed to knock down barriers in dealing with successful program management and deployment of a particular platform. In this case, the Salus IPT was comprised of several different individuals, including a product manager, somebody responsible for looking at project execution, and determining deadlines, cost and schedule, etc. We also had a mission lead, someone solely responsible for working with our end users, ensuring that the development of our project was going to help meet the demands of those particular individuals. And uniquely, the integrated project team for Project Salus also included various stakeholders. In this case, we brought together analysts from different represented organizations that were going to be using our particular platform. This included interagency partners, including FEMA, HHS, etc. But in addition, we also brought together representatives from combatant commands, as well as the National Guard headquarters. In addition, we had several different subject matter experts, ranging from data science, testing and evaluation, policy and legal, infrastructure, and also individuals to help us rapidly develop and deploy contracts. Together, this team worked to help build the success of what we view as Project Salus. What I'd like to do now is turn it over to Dr. Experton and allow her to discuss some of the models that were built as a result of this IPT.
Thank you, Dr. Walker. To conduct predictive COVID-19 analytics for Project Salus, we followed the Medicare population at high risk for severe COVID-19 disease, with a population cohort of over 18 million Medicare fee-for-service beneficiaries, including 2.5 million COVID-19 cases at the end of March 21. This population cohort accounted for over 50% of total US COVID hospitalization and deaths. The analytics platform run in a secure enclave of the DoD, processing every week over 100 million CMS claim data. Then we produce validated individual risk profile for severe COVID-19 disease, displayed on a nationwide risk map at the county and zip code level. For conducting then vaccination monitoring for equitable allocation, efficacy, and safety, and monitoring long COVID disease. The data sources for the risk model use de-identified Medicare claim data for encounters starting in October 2019 for clinical and demographic risk factor. And with regard to SDOH risk factors, we extracted data from the CDC SVI data set. Then we conducted multivariate logistic regression and random forest analysis. Our risk model output and application included the identification of new predictors for severe COVID-19, in addition to the one initially identified by the CDC. We risk map that population at the zip code and county level, conducted population risk stratification for COVID-19 vaccination prioritization. Next, my colleague, Dr. Chris Burrow, will demo for you the Project Salus Medicare dashboard.
Well, thank you, Dr. Experton. And in this part of the presentation, I will show you the dashboard created for Project Salus. Here on the first view of the dashboard, you see the national map showing in blue-green colors the confirmed case rate per 100,000 of this over 65 population, and in red, showing actual case counts. On the right, you see that we have totaled up all the confirmed cases that were shown as of this date, as well as fatalities. Further on the right, you see we have a time series for the county with the highest number of cumulative cases, which is Los Angeles. Switching over to the hospitalization map, you see here we have, again, hospitalization rates colored in counties in maroon and beige, and we have actual hospitalizations symbolized by circles. And on the right of the map, you see that we also have other outcomes, including hospitalization, ICU cases, and ventilator cases that we've derived using algorithms in the Humetrix platform analyzing the Medicare data. As Dr. Experton mentioned, we've applied the logistic regression coefficients to 18 million individuals in the Salus cohort. And here we're coloring counties according to the percent at highest risk of COVID-19. And looking at this map, you see different areas in darker color. And I'm going to show you the comparison with the Social Vulnerability Index risk map that others have sometimes used to find high-risk areas. The two maps are not exactly the same. Ours is more focused, and I will show you that again in a moment at a zip code level. I'm going to turn to how this model was validated, and this map shows the risk map, but overlaid with the hospitalization cases. And you see in darker colors, areas where there is a high case hospitalization rate, which at the county level looks like it overlaps with higher risk areas. We've examined that further at the zip code level. This is Los Angeles. And what you can see here in darker colors are high case hospitalization rates overlapping with, in lavender, high risk areas, and conversely, low risk areas showing low case hospitalization rates as shown by the white circles. We validated this model in 15 major metropolitan areas using linear regression, comparing the risk on the x-axis with the cumulative case hospitalization rates. The R values in all of these areas are consistently above 0.6. Turning now to vaccinations, we're showing in light green single vaccinations, in dark green completed vaccinations, again overlaid on the risk map to address an important question. Are the areas at highest risk receiving the most vaccinations? Here again, we're comparing the risk in Washington, D.C. area to the SBI index map, and you will have seen that the higher risk area shown in dark lavender on our risk map overlaid with vaccinations is not exactly the same as the SVI map. But more importantly, at this point, you see that vaccinations are predominantly not occurring in the highest risk areas shown in dark purple. Using processing of data, we've also examined vaccination disparities. and mapped out the regions in the United States that are performing above average for vaccinations in dark blue and below average in red. Again, we can look down at the zip code level, and this is Los Angeles, and I've picked out an area shown in brick red that has a lower than average vaccination rate. In the pop-up showing about 5%, the national average is 16% at this date and time. So this gives us an ability to follow the vaccination campaign. And then finally, a very important question is, has vaccination allocation and administration been equitable? In red are counties that have a underrepresentation of minorities in the vaccinated population, and these are ranked on the left by county. Looking in at the zip code level with Washington, D.C., we see in red areas where there is an underrepresentation of minorities in the vaccinated population. And you can see that clearly looking at the pie chart on the right. On the top, the pie chart shows the distribution of ethnicities in the vaccinated population compared to the cohort ethnicities in the region shown on the map. With that, I'm going to turn the presentation over to Dr. Tete, who will provide a wrap-up and concluding remarks.
Dr. Walker, Dr. Experton, Dr. Burrows, thank you for a fantastic presentation. Today, this validated risk model combined with a high-performing Project Salus COVID-19 predictive model can actually help target vaccinations to regions with intensifying disease spread associated with emergence of the new variants. With the rapid strategy that was just presented, in addition with the integrated product team models and the approach, Project Salus has developed a validated set of models that can provide critical insights for effective pandemic response. In combination with our partners and with the JAKE, what we hope that we've demonstrated is the showcasing of how you can lead in AI adoption at scale, accelerate AI adoption, provide an enterprise service, and create an AI-friendly environment toward a good end and high utility. Thank you so much for your attention, and we welcome your questions.